आदित्य,
Yes, sir. Now we are live, sir.
हाँ बताओ यार.
Just now we are live, sir.
Kishore, we can start. Go ahead. Okay.
Yes, sir.
Yeah, thank you, sir. Good morning, all. Today we'll be discussing the most important topic of ICU care, that is approach to delirium in the ICU. I'm Dr. Nandkishore, and I work as a senior intensivist at Pulse Super Specialty Hospital. I thank HICS team to giving me this opportunity. And today we'll be discussing about this topic in detail, the risk factors of delirium, the pathophysiology, the clinical approach, and management of delirium. So, why is it so important? Why this topic is so important for the current uh, care of intensive care is because delirium still is one of the most common symptoms or syndromes in the ICU, but often neglected entity. And despite decades of research and identification of numerous risk factors, our understanding of delirium remains a major challenge. Till today, we don't clearly understand why patients go into delirium and what are the exact reasons and how do we exactly approach and nullify this risk factors of delirium. And why is it so important is because it is one of the most common psychiatric syndrome among all the other psychiatric syndromes. Delirium is one of the commonest psychiatric syndrome that we encounter in the ICU, and yet it is frequently underdiagnosed and often missed. And it has a very high prevalence amongst the known psychiatric syndrome. If you look at the various psychiatric syndromes like dementia or withdrawal or agitation or any other behavioral abnormalities or other psychiatric syndrome, the prevalence of delirium is almost close to 60 to 80% among ICU patients. And as I told, due to its complex etiology and pathophysiology, it is not often completely understood, and that is the reason it remains under-recognized and underdiagnosed, and it has very limited therapeutic options. It is one of the challenging disorder where it's very difficult to treat, and we have very limited therapeutic options, and it is associated with increased morbidity and mortality. If a patient's in the ICU develop delirium, that is one of the most independent risk factor which is associated with increased morbidity and mortality. And of course, due to prolonged stay in the hospital and prolonged stay in the ICU, the cost increases, the expenses goes up, and increased hospital acquired complications do happen when a patient develops delirium. And the most important aspect is the development of the post ICU cognitive impairment. Majority of the patients who develop delirium in the ICU spends increased length of stay in the ICU. After going home, they develop something called as post-intensive care syndrome, and which is a varied spectrum of symptoms which we see, and this can exist even up to 1 to 2 years of post-ICU care, and that is why we need to prevent this delirium in ICU patients. And development of this post-ICU cognitive impairment is often underlooked, and we need, as a clinicians, we need to make sure that this is followed up and patients are treated in a timely manner. And it, of course, decreases the quality of life, prolonged hospital and ICU stay, as I told, and longer days of mechanical ventilation. So, even more reason why we discuss this topic today, it has become a substantial economic burden and increasing the cost of patients admitting into the ICU. So if you look at the delirium and mortality, as I told, the longer the duration of delirium, the higher the mortality. If you see this study published in 2009 Journal of Critical Care, where they have seen the 6-month mortality of patients getting admitted into the ICU who had delirium and who didn't have delirium, the number of patients, the rate of 6-month mortality is very, very high in patients who have delirium, and it increases the hospital stay and the post ICU stay. And as I told, there is a 10% increased risk of death per day of delirium. That means if the patient is having a delirium for 4 to 5 days, the risk increases exponentially by 10%. So this is why it is very, very important and prudent that we discuss this topic today. So what is ICU delirium exactly? Is there any standard definition for it? Uh, uh, this the actual definition of ICU delirium is a bit complicated and a little bit less understood, but I'll try to put it in a pictorial representation. Delirium the main component of delirium is probably one, that is a disorganized thinking, and the second component is altered mental status. And this altered mental status can either be an acute onset or it can be a fluctuating way. So, when a patient in an ICU develops an acute change in the mental status, which is often fluctuating, and there is also disorganized thinking along with some cognitive impairment, he cannot do simple cognitive parameters when tested. And apart from this, patient also has a significant mood change. As we all know, there are different types of delirium. I'll come into the next in the coming few slides. This is hyperactive delirium, hyperactive delirium. Patient may become extremely agitated. May be very drowsy and lethargic. And these mood changes and subtle changes in the cognition is also a part of ICU delirium. And the other important part is inattention. The patients don't pay attention to what we are doing, and this keeps fluctuating. And of course, there is a psychomotor agitation. So, I told these are the different components when you define ICU delirium. These are all the components which are present in the ICU delirium way. And patient, it is not compulsion that patient should have all these components, but generally they present with an acute fluctuating altered sensorium, with a disorganized thinking, and probably having a cognitive impairment with a mood change and lack of attention along with a psychomotor agitation. So for all the listeners and DRMB students going to for the exam, it is an ideal way of representing a definition of delirium. So clinical features of delirium, as I told, we'll go into the details. It should be an acute onset, generally occurs abruptly over a period of few days to hours, and it is always a fluctuating course. Symptoms tend to increase or decrease in the severity based on our 24-hour periods. And one more important point to remember is there is a characteristic lucid interval. Matlab in between, the patient has a normal interval where he appears normal. So the characteristic feature of delirium is it's an acute onset with a fluctuating course and lack of inattention, as I told, difficulty in focusing, sustaining, and shifting the attention, and difficulty in maintaining the conversation and following the commands, and disorganized thinking, manifested by disorganized and incoherent speech, and some rambling or irrelevant conversation or unclear or illogical flow of ideas, and altered level of consciousness. We usually call it as a sundowning or maybe a clouding of consciousness with reduced level of clarity, and cognitive defects. Typically, there is a defects in the cognition, disorientation, memory deficits. If you give them a simple task like additions or subtraction, they may not do. If you ask them a simple logistic reasoning, they may not give this thing. And perceptual disturbances. There could be an illusions or hallucinations. Previously, there were these illusions or hallucinations was not included, but as per the recent guidelines, they have also included the perceptual disturbances as a feature of delirium. And of course, the psychomotor disturbances, as I told you, the variants of delirium, the patient can be agitated, hyperactive, hyperactive, or mixed. And definitely, there could also be a altered sleep-wake cycle pattern. The sleep cycle pattern disturbances are classically seen in majority of the patients of delirium, and typically they have daytime drowsiness, nighttime insomnia, fragmented sleep, and complete sleep cycle reversal can also be seen in some subset of patients, and emotional disturbances commonly manifested by intermittent labile symptoms of fear, paranoia, anxiety, depression. These are the different emotional disturbances that we see in a lot of patients with delirium. So when we talk about delirium, all these aspects of delirium we have to see in that patient, and we have to come to a conclusion. So basically, delirium is a diagnosis of exclusion. You think of delirium, you put all these things, whether the patient is having acute onset, fluctuating course, is there any cognitive dysfunction, is there any behavioral changes, is there any agitation, sleep cycle pattern disturbances, all these things put together will feature your clinical part of delirium. So if you look into the pathophysiology of the delirium, this is the most important part of understanding our pathophysiology of delirium. The primary thing which happens in the delirium could be an insult to the brain. It can be a stroke, it can be a bleed, it can be any other acute insult to the brain, like a traumatic brain injury. When there is an acute insult to the brain, or in the form of any hypoxia or hypercarbia or hypotension, these are the main important triggers of the brain. This causes an ischemic damage to the brain, that is the primary insult, along with a acute inflammatory process that runs in the body. For example, like an infection or a surgery or a stress. These put together, they cause a series of events. They cause a change of or a distraction, disruption of the homeostasis. This leads to the limbic hypothalamic pituitary adrenal axis dysfunction. So the major hallmark feature of understanding of pathophysiology is your LHPA dysfunction. That is the limbic hypothalamic pituitary adrenal axis dysfunction. This leads to increased cortisol level. This leads to the disruption in the lot of chemical neurotransmitters that has been released in the major parts of the brain. And also the other part which we see here is the neurotransmitter imbalance. So there are a lot of neurotransmitters that release in the brain. For example, your dopamine, your serotonin, your GABA, glutamate, norepinephrine, and acetylcholine. And these imbalance in the neurotransmitters lead to abnormal firing of the neurons, leading to the various clinical features that we see. Like we see hallucinations, we see disorganized thinking, and all these things are probably due to the neurotransmitter imbalance and their limbic hypothalamic pituitary axis dysfunction. So if you look at the major parts of the brain system, the important areas where these happen is number one is the basal ganglia. Number two is the locus coeruleus, where the processing of thought process happens. And the basal ganglia, we all know it's a major center for your spinothalamic tract, where your reticular activating system is present. And this, along with the locus coeruleus, where the thought process is formed, along with the mammillary bodies, along with prepons and tegmentum, all these areas of the brain, there is a neurotransmitter imbalance that happens. This neurotransmitter imbalance leads to your onset of your delirium. So basically, the main idea is understanding is your dysfunction of the limbic hypothalamic axis and the neurotransmitter imbalance. So the other important pathophysiology which they have prognosticated is the abnormal tryptophan metabolism. So when patients have this abnormal tryptophan metabolism, there are two pathways in the tryptophan metabolism. One is excitatory pathway and is the inhibitory pathway. When there is an excitatory pathway, the tryptophan gets converted into tryptamine and NDMT, leading to the excitation, which we call as hyperactive delirium. And if goes into the other pathway, this tryptophan converts into serotonin and increased melatonin. Patients will be drowsy, sleeping for excessive time, and increased somnolence, which we call as a hyperactive delirium. When this is the basic pathophysiology of understanding of delirium. So if you look at the microcirculation level, what exactly happens at the microcirculation level? At the microcirculation level, we can see the disruption of blood-brain barrier. We can see cerebral energy failure. We can see neuronal inflammation, neuronal injury. We can see what is called as, I discussed, the neurotransmitter imbalance and the neuronal injury. That is a reduced BDNF. That is the one which we call it as a brain the brain derived neurotropic factor, BDNF. So these molecular changes basically, as I told, neurotransmitter disruption at different areas of the brain. And one we call it as a astrocyte lactate shuttle, where there is an increased lactate production at the neuronal level. What happens at the neuronal level is there is a increase, there is a change in the glucose transporters which happen, and this glucose transporter will cause increase in the pyruvate metabolism, ultimately leading to the increased lactate production. And this increased lactate production at the neuronal level, due to hypoxia or various reasons, can cause shuttling of lactates from astrocytes to the healthy neurons. This accumulation of lactates in the astrocytes of healthy neurons is probably one more reason why patients develop delirium. So here, the diagnostic testing of near infrared spectroscopy or measuring the lactate levels in the cellular level at the brain can probably help you in understanding the patient why he developed delirium. So these are the molecular changes at the microcellular level. So if you look at the incidence, what is the incidence of delirium? The incidence of delirium is as high as 40 to 80%. So if you look at the incidence of delirium, which patients have more incidence of delirium? The patients getting admitted into the medical ICU, they have high incidence of delirium, 60 to 80%. And the patients admitted into the surgical ward, they must have almost close to 50% of incidence of delirium. Patient undergoing a major surgery, for example, like a CABG or a cardiotomy, they can have a major incidence of delirium. And if you see patients post-operatively, elderly patients having fall, sustained IT fracture or a hip replacement, they can also have a high incidence of delirium. And patients having advanced cancer can also have a high incidence of delirium. And if you see in the ICU, the most important factor which increases the incidence of delirium is your mechanical ventilation. So patients who are on mechanical ventilation are bound to have delirium as high as 85%. So the most important triggering factor for delirium in your ICU is probably mechanical ventilation. The second important factor is the duration of time the patient is in shock. The patient is in shock, the duration of time the patient is in shock, this also decides your incidence of delirium. And the other two important factors is advanced age and probably the Apache score. If you see the advanced age, the more the advanced age from 60 onwards, the incidence of delirium goes up significantly. So advanced age is also an independent risk factor for your onset of delirium. And as well as high admission Apache scores can also increase your delirium. For example, a patient is very sick whose Apache score is very, very high at the time of admission, the more likely chances that this patient can develop in delirium more likely than other patients. So, so what are the risk factors? As I told, the risk factors, there are multiple risk factors which contribute to delirium in a patient. Premorbid risk, I would like to differentiate them into premorbid risk factors and the other risk factors. The premorbid risk factors are the risk factors which in which the patient tend to have more frequently. Like for example, if the patient is having a pre-existing dementia or a depression or prior history of delirium, or a decreased functional status, poor quality of life, decreased immobility, frequent history of falls. These are the subset of patients where they tend to develop delirium more frequently. And also, not to forget, visually impaired patients having hard of hearing. The frailty comes into the picture. Frailty is one more most important concept which is now evolving in the ICU. And frailty itself is a direct independent risk factor for the occurrence of delirium. Malnutrition, dehydration, and the other important risk factor in this part of our country is our alcohol dependence and advanced age. More number of comorbids. The number of more comorbids you have, the more chances of the delirium you get. And the drug abuse, different drug abuse like psychotropic drugs, sedatives, and opioids. These are all the premorbid risk factors. And looking at these risk factors, probably at the time of admission, you take a history and you look at all these checklists. If the patient is at the day one has more than 3 to 4 features of these premorbid co-risk factors, you should keep in mind that this patient has probably a possibility of going into a delirium. So factors related to concurrent illness are clinical risk factors. Any clinical condition that the patient develops during the which can be the reason for ICU admission, whether it can be a sepsis, whether it can be a pneumonia, whether it can be any clinical condition or a neurological condition with which the patient gets admitted, itself is a risk factor for the development of delirium. And the other important risk factor is the surgery. We have seen data shows that surgical patients have increased incidence of delirium, and electrolyte imbalance is one more independent risk factor for delirium, most commonly or hyponatremia. And ventilation more than 96 itself is an independent risk factor for occurrence of delirium. And the post-admission factors being post-surgical settings, especially the pain. Poor pain management can also lead to your increased risk of delirium. Irrational use of steroids and more use of opioids can also can be contributed to the risk factors of delirium. Sleep disturbances, day-night orientation, over sedation, lack of communication with the patient, and restraints, physical restraints especially, is one of the most common important risk factor for the development of delirium. So these are the things which we need to keep in the mind while assessing a patient with delirium. Then this assessment should not start when the patient develops delirium. This assessment should start from the day one of admission. When a patient is getting admitted into the ICU, you need to take a clear history. What are his habits? How was his physical quality of life at home? Whether he was mobile or immobile? Were he using any psychotropic medications or any dependence medications? Was he having recurrent admissions in the past? Did he undergo a recent surgery? Any major electrolyte imbalance that happened in the last 6 months? All these things we need to note and take a proper checklist. And probably this helps you in understanding that this patient might develop they might have a high chance of developing delirium. So, put in a single nutshell, the mnemonic for risk factors for ICU delirium, this comes with an ICU delirium, where it is an iatrogenic exposure, drugs, use of restraints, infections, and all these things. And these are the list of drugs which can cause delirium directly. And the most important thing which I want to tell you is the excessive use of anticholinergics. Many of the drugs inherently have an anticholinergic mechanism, and these anticholinergics have been attributed for the development of delirium. Apart from analgesics like opioids and benzodiazepines, the other important drugs which you need to remember is the anticholinergics. So, what could be the other contributory causes? As I told, the pain, agitation, all in delirium, all these three are intercoordinated fashion. The one will trigger and cause the other problem. If there is an inadequate control of the pain, that can lead to delirium, and delirium again lead to agitation, and pain can also lead to agitation, and this is a vicious cycle. So the three main domains of managing a delirium patient lies in inadequate pain control, probably trying to reduce the agitation will help in the reduction of this delirium. So, what are the subtypes of delirium? So, there are delirium can be classified into several subtypes according to the different characteristics reflecting heterogeneity in both clinical presentation and underlying mechanism. The most widely accepted classification of delirium is based on the psychomotor activity. This is the subtypes of delirium based on the psychomotor activity. That is the hyperactive delirium, hypoactive, and the mixed. And hypoactive is the most underdiagnosed and has a very poor prognosis amongst this subtype of delirium. Hyperactive is easy to identify. The patient will be very restless, very agitated. It's very easy to identify and easy to treat. But hypoactive delirium is often underdiagnosed and is difficult to treat entity. So, is there any other classification of, if you see the hyperactive differences, the physiological and behavioral changes? As I told, the cognition, there is the speech is loud, incomprehensible, and disorganized. There are perceptual disturbances in hyperactive, leading to hallucinations, delusions, and disorientation. These perceptual disturbances are not seen. If you look at the low voltage fast EEG, there is an increase in the cerebral metabolic activity, this is the abnormal cerebral activity and the decreased GABA activity. And here the EEG shows the decreased cerebral metabolic activity and increased GABA activity. And there is an immense behavioral changes in hyperactive type, whereas in the hyperactive type, the patient will be apathetic and decreased response to the stimulus. And the possible etiology for hyperactive could be most commonly in our setup will be in alcohol withdrawal or drug intoxication. And here there are metabolic disturbances which cause more of hypoactive delirium. So the other phenotypes in delirium, this is the latest concept which they have come with. There is a heterogeneity of we have discussed the subphenotypes like the psychomotor based, and apart from the psychomotor based clinical subphenotypes, there is also a precipitant based subphenotype or a risk based subphenotype. So the reported incidence of psychomotor subtypes is generally around 20 to 30%. But importantly, the predominance of these highlights a diagnostic gap. That means it's subtle manifestations and often escapes the detection, contributing to the worse outcomes. Consequently, there is another variant called as a biologically driven subtypes. What is the biologically driven subtypes, which would more accurately reflects the pathways between the precipitating and predisposing factors. For example, the precipitant-based division. The precipitant-based subphenotype of delirium includes septic, hypoxic, metabolic, sedative-associated, and unclassified delirium. Among these, sedative-associated delirium appears more frequently, and prolonged episodes of delirium have been linked to the poorer cognitive performance. So this emphasizes that the current limitation of subphenotypic models in predicting the outcomes is little bit less, and we are looking forward into the more variants, that is the endotypes, the identification of delirium endotypes, which is defined as a distinct biological mechanisms based. Probably you can uh, differentiate based on neuroinflammatory, non-inflammatory, or oxidative stress driven. So just like any other disease which has phenotypes, for example, ARDS has a different phenotypes. Traumatic brain injury has a different phenotypes. Similarly, there are different phenotypes in the delirium. You need to understand and delineate the type of delirium, the type of phenotypes, and the endotypes. So a patient might have a neuroinflammatory endotype of delirium, but a psychomotor based delirium. So first you need to classify the subphenotype, whether it's a psychomotor based delirium, precipitant based delirium, or a risk based delirium. And then you need to identify the what is the endotype. Is it a neuroinflammatory? Is it a generalized inflammatory leading to a cytokine storm, or is it an oxidative stress driven type of delirium? So, what are the different assessment tools in the ICU? There are different tools. Most widely tools for the diagnosis of delirium are the confusion assessment method for the intensive care, that is the CAM ICU, and the intensive care delirium screening checklist, that ICD-SC, and the delirium screening tools, the screening scale, Nealon and Champagne confusion scale. These are the different delirium assessment tools which we use regularly in patients assessing the delirium. And the most commonly used is the CAM ICU method, the confusion assessment method. So it is done for intubated patients, and it should be used by health professional not specialized in psychiatry. And the sensitivity of application of this CAM ICU method is 95 to 100%, and specificity is 89 to 93%. How do you assess it? First, you assess the mental status of the patient. It's very simple. First, you see the acute onset of mental change or a fluctuating course, and then you check for inattention. And after checking the inattention, you see what's happening to whether there is a altered level of consciousness or disorganized thinking. So, how do you assess the altered level of consciousness? The first step is to assess the level of consciousness by RAS scale, that is the Richmond Agitation Sedation Scale. By this scale, you assess the level of consciousness, and after that, the next step is assessment of the content of the consciousness. I mean, how far is the consciousness affected? Is it having any disorganized thinking? Is there any lack of attention? Is what you think. So this is a simple flow chart. First, you see both whether there is an acute onset of mental change with fluctuating course along with inattention. Then you look for change in the altered level of consciousness or disorganized thinking. So how do you assess the level of consciousness? This is the RAS score. By using a RAS score, if the patient is less than 0 or less than -2, then you proceed and assess for a delirium checklist. So the first step is you assess the level of consciousness. If the RAS scale is like -4 or -5 or less than -2, probably you need not assess further for the delirium because the patient is appropriate. If the RAS score is -3, that means the patient is having appropriate response. The patient briefly awakens to voice, and probably when there is a RAS score of -2, he can easily open eyes and he can give an eye contact for more than less than 10 seconds. And if the patient RAS score is less than -1, probably the patient is not fully alert, but sustaining awakening can be there. So if the patient's RAS score is more than 0, it is pertinent that the patient is probably having a delirium, and you go for the next assessment. So this is the flow chart of assessment. First, see whether there is an acute change or fluctuating course of mental status. If there is no, that means there is probably no delirium. You need to look for other causes of altered sensorium. And if this is present, then you see whether the patient is having inattention. There are a sequence of things suggested by the ICU where they have given some sequence of things, and you need to apply this in your patients, and you see whether the patient is attentive enough or inattentive, and then you decide whether there is a delirium. If there are more than 2 errors, then probably your patient might be having a delirium. If the patient is showing 0 to 2 errors, probably there is no delirium. Then after assessing these two, next assess the level of consciousness using the RAS sedation scale. And if the RAS other than 0, if the RAS is other than 0, it might be a -2 or +2, then probably the delirium is in the cards. If the RAS is 0, then look at what's happening to the thinking process. What's happening to the thought process? Is it disorganized or is it okay? You asked him some common questions regarding the organized thinking, and you will know whether there is a disorganized thinking. If there is more than one error in assessing the thought process, probably delirium is present. And if there is 0 to 1 error, probably there is a no delirium. This is how you look at and assess the patient's delirium. So, what are the other neuroimaging techniques in a delirium? So, when a patient develops delirium, is it prudent to do a neuroimaging? Yes, because delirium is just a diagnosis of exclusion. Before coming to a conclusion that this patient might be having a delirium, you need to rule out all the confounding factors. You need to rule out metabolic abnormalities. You need to rule out dyselectrolytemia, hypoglycemia. You need to rule out any infection. You need to rule out any neuro with a neuroimaging. So, what does neuroimaging have a role in the patients with delirium? Mainly to identify the structural and functional brain changes that take part in the patient when there is a delirious process going on. So the commonest modalities used are different modalities. They have tried MRI, CT, the diffuse tensor imaging, the transcranial Doppler, the NIRS looking at the lactate levels at the cellular level, functional MRI. Functional MRI nowadays has been a more advanced modality of imaging, which we are using regularly in a lot of patients. The MR spectroscopy, arterial spin labeling MRI is one thing which is used in early stages of ischemic stroke, and again comes into the picture in the delirium and PET scan. All these modalities, there is some role. And what do you look at when you do a neuroimaging in a patient with having delirium? So you look at what's happening to the brain volume. Is it reduced? What's happening to the white matter hyperintensity? Is there any disrupted functional connectivity when you do a functional MRI? Is there any impaired cerebral autoregulation when you do a arterial spin labeling MRI? Is there any decreased cerebral blood flow or oxygenation or glucose hypermetabolism? Is there any increase in the lactate levels that happens at the cellular level? Is what you look at all these in neuroimaging techniques. So why do we need to know about all these things? Because they indicate the long-term neurological changes following delirium. When a patient with delirium who got admitted to the ICU, when you do all these functional MRIs and other forms of neuroimaging techniques, and you find that there is a lot of white matter hyperintensity with decreased functional connectivity and decreased cerebral blood flow with altered regulation, probably the chances of this patient having a long-term neurological insult is very high on the cards. Probably this patient developing a post intensive care syndrome in the next 6 months to 1 year is very, very high. The other important investigations are the EEG. You do a bedside EEG in a patient having uh, delirium. You observe increased relative delta power and decreased beta power on a bi-electrode EEG, which can be served as a reliable marker of a delirium. So, apart from neuroimaging, the best bedside investigation probably you do a EEG, because majority of the times non-convulsive status epilepticus is one condition which stands out as a confounding factor for a delirium. If a patient is hypoactive and not responding, and this patient might be having also a non-convulsive status epilepticus. So it is very much prudent to do an EEG, not only to rule out a status epilepticus, but also to see what's happening to the delta power and the beta power. In this case of delirium, there is an increased relative of delta power and decreased beta power, which can tell you that probably this patient is having a delirium. Are there any biomarkers? Yes. S100, the S100 calcium binding protein B, the neurofilament light chain, and the glial fibrilic acid glycoprotein, that is the GFAP. These are the three neuromarkers. Of course, these three neuromarkers are studied in multiple pathophysiology of the brain. They are studied in traumatic brain injury. They are studied in ischemic strokes, all these things. But S100 elevation indicates that there is a glial activation in response to neural inflammation. That means it tells you that there is some neuroinflammation happening, and it may be due to an ischemia or a metabolic disturbances. It may not tell you that this patient is having a probable delirium. The elevation in the S100 doesn't always suggest that patient is having delirium, but it will definitely tell you that there is a probable neuroinflammation that is happening in the brain. And patients with elevated S100 beta levels tend to experience a longer duration of delirium. This is one thing. Probably you can keep a track of the trend of the levels. Look at what's happening to the elevation in the S100 levels. And if the S100 levels are persistently elevating, probably the patient might have experience of experiencing a longer duration of delirium. NFL is one more structural neuronal protein that is released in the presence of a neuroaxonal damage. When you see patients having a traumatic brain injury or a direct insult to the brain in the form of stroke or an IC bleed, this neurofilament light chain assay increases. And increase in the GFAB, the fibrilic acid protein, also increases the risk of postoperative delirium. So when a patient's coming with post-operative status, develop delirium. This is the biomarker which elevates in such subset of patients. So an integrated approach for the diagnosis, you do an EEG, you take a blood sample, send for biomarkers, you prepare the patient for neuroimaging, and along with this, you also perform a routine simple delirium assessment tools like CAM ICU or ICDSC. So they can be, and it should be performed within 1 to 2 minutes and should ideally be repeated at least twice a day. It's ideal to do 3 to 4 times a day, but at least it should be done twice a day. So the integrated approach is you put the assessment tools of delirium you in the patient, you assess the what is the delirium status, what is the CAM ICU score, is the patient having a probable delirium, and then do these investigations like EEG, biomarkers, and imaging. So how do you manage delirium? The management of delirium, it's uh, uh, cut down the contributory factors. You cut down what is triggering this delirium. You treat the underlying disease process, and there are, of course, the pharmacological management and non-pharmacological management. So in this, I would like to discuss there is something called as ABCDF bundle. You first is the assess, prevent, and manage pain. Both you perform a spontaneous awakening trial daily and spontaneous breathing trial. That means you give a sedation vacation, you stop the sedation, reassess the sensorium of the patient, which should be mandatory. You give a spontaneous breathing trial, and you should check the choice of analgesia and sedation which you are giving, which I will discuss in the next coming slides, and assess and prevent and manage the delirium. E is for early mobility and exercise, and F is for family engagement and empowerment. This is the ABCDF bundle which they have come across in preventing and managing this delirium. And this has been extended slightly in the recent guidelines to A to I bundle. They have increased GHI. So as I told, A assessment, assess, prevent, manage pain. You first assess the pain by using a behavioral analog scale or a CPOT or through other advanced modalities like a BIS or a ANI, and perform both SAT and SBT, prevent oversedation use, apply these sedation scales like a RAS scale and a sedation assessment scale, and set the daily targets, avoid sedation, over sedation, and you give daily sedation interruption. And D is for delirium. Use the validated scales like the CAM ICU and the ICDSC. Early mobility and exercise. F for family engagement. G comes with gaining insights like tailor to individual needs, like preferences and habits. The patient might have a preference of listening to music. Try to give them these preferences, colors, sense, assistive technologies for effective communications, and holistic care. H comes for holistic care, where the patient-centered care with home-like elements, like creating a familiar or a sound environment or a safe ICU environment, which looks similar to a home. And I stands for ICU redesign, probably changing the design of the ICU, where you have more lighting, more natural light, more view of nature and greenery, and the visual support. So these are the things which they have come up with the ABCD bundle. Uh, and one more thing is there should be a fine balance between sedation. The patient should not be over sedated or under sedated. If you over sedate the patient, probably there will be a poor cough reflex, respiratory depression, hypotension, bradycardia, immune depression, immobility, failure to recognize the cerebral insult, and this can lead to delirium. Under sedation also causes the patient to get agitated, pain, anxiety, hypertension, tachycardia, ventilator asynchrony. All these again can lead to your delirium. So there should be a fine balance between your sedative process. So if you look at the sedation, the effect of sedation, there is a MENTS randomized control trial which compared the sedation with dexmedetomidine versus lorazepam on acute brain dysfunction. And in mechanically ventilated patients managed with dexmedetomidine, the use of dexmedetomidine resulted in more days alive without delirium or coma rather than using a lorazepam infusion. If you see the delirium-free, coma-free days, the delirium-free days are more with dexmedetomidine, and the coma-free days are also more with dexmedetomidine, clearly suggesting that the use of benzodiazepines should be avoided rather than better to use a drug like dexmedetomidine. So this is one more study, that is a SETCOM study, which is published in JAMA in 2009, the safety and efficacy of dexmedetomidine compared with midazolam. Here they have clearly mentioned that the prevalence of delirium was more when with midazolam compared to dexmedetomidine. So if you use benzodiazepines, definitely the prevalence of delirium goes up significantly. And this is one more study where they compared three drugs. That is, they took two randomized control trials. One is the Midex trial and one is the Prodex trial. The Midex trial is between the dexmedetomidine versus midazolam, and one is between the Prodex is between the dexmedetomidine versus propofol. They compared these two studies and look at what's happening to the pain score. That is a visual analog assessment score, and how better the patient communicated, how arousable, how easily the patient is arousable, and how cooperative is the patient. All these parameters they have estimated, and they have come to a conclusion that the incidence of delirium is more with midazolam and propofol compared to your dexmedetomidine. So they have come to a conclusion that the pain scores or the ability to communicate with a patient and the arousability index or the cooperative of the patient is more with dexmedetomidine compared with your midazolam and propofol. So this is one more aspect I would like to mention in the management of delirium. That is sleep deprivation. This is often the neglected entity. Sleep deprivation is one of the commonest thing that happens in the patient in the ICU, because the patient will lose orientation between the day and night, and there is an alteration in the sleep pattern. The circadian rhythm changes. There is an abnormal sleep architectural pattern due to different medications, probably or sedation or pain management. The patient will be on mechanical ventilation. There will be noise. The alarms will be ringing 24 by 7 due to the acuity of the illness or the patient care interaction. All these risk factors put together, there is a sleep deprivation in the ICU. So what does it lead to? It causes altered outcomes. It causes altered immune function. It causes increased stress, fatigue, delirium, and decreased concentration. So what is the pathophysiology of the sleep disturbance? As I told, there is something called as a biological clock inside the brain, and this biological clock is maintained by the pineal gland, where melatonin plays a major role. And the extensive studies have been done regarding the role of melatonin in the alteration in the sleep pattern. And if you see, the major neurotransmitter which is involved is the tryptophan. The alteration in the tryptophan, as I told in the first slide, there are two pathways of tryptophan, either leading to hyperactive and hypoactive. The hypoactive part, where the increased somnolence, the tryptophan changes to 5-HT, the 5-HT serotonin changes to acetylserotonin, and this leads to increased melatonin, and this increased melatonin leads to increased somnolence. This is how the biological clock is maintained, and the sleep deprivation and delirium are the interbalance between the disruption in the neurotransmitter and the amount of melatonin. So the melatonin and the neurotransmitter decide these two things, the sleep deprivation and the delirium. So this is the delirium prevention checklist. So in this, you need to make sure that all these things are achieved, optimized, so that your patient doesn't develop delirium. Assessment of consciousness regularly, give a break to the sedation, reassess his GCS, promote reorientation, ask him what's the day today, what's the time, and what's the where he is. Compare the baseline and document the changes. Assess the depth of sedation using assessment scales like RAS. Prevent over sedation. Assess the pain using validated scales, and use a multimodal analgesia rather than a single agent. Use multimodal analgesia and reassess the pain. Sensory optimization and family engagement is also most important. Provide them glasses, hearing aids, and optimize the lighting. Ensure the orientation tools like the clock, calendar, and whiteboard. And sleep hygiene and circadian rhythm also should be maintained. And make sure that there is early mobilization and physical therapy. So coming to the non-pharmacological information, as I mentioned in the previous slides, I would like to differentiate this into Tier 1, Tier 2, and Tier 3 strategies. Tier 1 strategies are easily implementable, low resource measures. You need not do anything major to implement these Tier 1 strategies. They are easily implementable, cost effective. Just you optimize the sensory input of the patient. If the patient has hearing aids, give it to him. If the patient has glasses, give the eyeglasses to him. And providing cognitive cues, providing a clock in front of him, put a calendar in front of him, put some family photos in front of him, so that you're trying to improve the orientation and cognition of the patient. Reduce noise as much as possible. Minimize the nocturnal interruptions. Minimize the bed transfers. Minimize the change of positions, especially in the night. Promoting sleep is the most important thing which you can easily implement, avoiding unnecessary blood transfers and ensuring continuity of the nursing staff. Type 2 strategies are moderately demanding interventions. It's not very easy to apply or not very easy to implement. There's nothing but structured reorientation protocols. Probably need to change your direction of the bed, the position of the bed towards more natural light, maintaining appropriate ambient lighting, controlled exposure to the nature where you put some indoor plants and greenery so that the patient feels like more of nature, and adapting virtual reality. Virtual reality is nothing but arranging a meeting kind of thing with the patient's attendance and his own family members and friends, adapting a virtual reality and digital therapies. Though it is a little bit cumbersome, these type 2 strategies often work. And the type 3 strategies are the high resource architecture dependent interventions. Probably you need to redesign the ICU, comprehensive redesign of the ICU, create a separate spacious rooms and separate rooms for both staff and the family corridors, improve acoustics so that the noise is less, enhanced ventilation, and direct access to outdoor and indoor gardens. Probably these strategies we might see in the next coming. Already many ICUs have been equipped with such high resource architecture dependent interventions. But in the coming future, almost every ICU should adapt such a comprehensive ICU design. So the role of drugs, the pharmacological intervention, what is the role of antipsychotics in delirium? The trial done in 2010, that is a mind randomized control trial, which studied the efficacy and safety of antipsychotics. They compared basically haloperidol and ziprasidone and found that haloperidol has more length of stay and more chances of delirium in patients. And when compared to dexmedetomidine versus haloperidol, the time to extubation and the total length of stay in the ICU, time to ICU discharge, all increase significantly when compared to dexmedetomidine. And to summarize, delirium is a syndrome and it should be identified and treated early. And it is often associated with post ICU cognitive impairment, which we call it as post intensive care syndrome. And pre existing dementia, alcohol, and other comorbids are potential risk factors for delirium. And routine monitoring of delirium in the ICU is a must. We should make sure that the checklist of delirium starts from day one itself. Just like we do a checklist for a lot of other procedures, we also need to inculcate the routine monitoring of delirium and look for the checklist of the delirium regularly in an ICU patient. CAM ICU and ICDSC are the best assessment tools so far for assessing the delirium in patients. Early mobilization reduces the rates of delirium, and benzodiazepines have shown to have increased rates of associated with increased rates of delirium. So wherever possible, try to avoid benzodiazepines. In few cases like severe alcohol intoxication and withdrawal, probably you can use benzodiazepines, but benzodiazepines should never be used as a routine care for delirium. And dexmedetomidine use of sedation instead of benzodiazepines might decrease the incidence of delirium, which has been very much appreciated in a lot of trials. No evidence to support that haloperidol use to decrease the duration of the delirium. So haloperidol should neither be used as a prophylactic agent nor should be used as a agent of choice to reduce the delirium. And reducing the pain should be routinely monitored. The routine monitoring of pain should be adapted in all patients admitting into the ICU by using like simple scores like the behavioral pain scale and the CPOT. And preventing pain is more effective than treating an established pain. Treating an established pain is very, very difficult. Rather than you try to prevent the pain and you address the pain more early before it gets established. And administer analgesics on a continuous basis rather than a intermittent boluses. You can also give a supplemental boluses as required. And IV opiates are usually the first line of choice to treat patients in the ICU, but the dose should be minimized due to the fear of tolerance. And maintain very light levels of sedation so that there is a shorter ventilator days and decreased length of stay in the ICU. And and SAS are the most valid and reliable sedation assessment tools. And whenever sedating a patient, you should always choose a non-benzodiazepine sedatives, either a propofol or a dexmedetomidine, to improve the clinical outcomes. And daily sedation interruption must be done to assess the patients. Daily SATs and SBTs should be in the norm in patients who are on the ventilator. And you should always choose an analgesia for sedation. The analgesia component should be more than the sedative part. and this should be preferred in mechanical ventilated patients. Thank you.
Thank you, Kishore, for taking through the concept of delirium in a very, very comprehensive way. Uh, Totally agree with you uh, on the fact that most of us don't see it as a diagnosis, right? Most of us don't actually mention that in our notes as a possible cause for altered mentation, but it's something that we should keep in mind. Be familiar with the habits and addictions of your patients, because a good number of time when you go back and check the history, they might be addicted or they might be used to some certain kind of medication, or simple adjuncts like your reading glasses, spectacles, all these things, and lack of them can contribute to the onset of delirium. Uh, though not a very, very strong recommendation, the recent Paris guidelines do mention the use of melatonin, as an adjunct to streamline your sleep. Again, the strength of evidence is not very strong, but it's something that can be easily tried to kind of set the sleep cycle in majority of the patients where the sleep cycle is disturbed. Thank you, Kishore. Thank you very much.
Thank you, sir.
And if you have any doubts or any queries, please do write to us. We'll get back to you with the solutions. Thank you, Kishore. We'll see you next week
Thank you,
again.
sir. Thank you, sir. Thank you, sir.